Good afternoon, all. I hope you're having a wonderful day. Let's see if we build a little bit of an audience. Um, we're getting back to advocacy and action, healthcare, navigating the healthcare system. And I'm Carmen Coffin, and I am happy to have you here with me today. Tell you a little bit about myself. Um, how did I get here? I lost a child to violence, was diagnosed with a rare disease, and on oxygen 24/7, caring for a sick child and a husband. In 2011, I decided to come home for 6 months to take care of myself, and I never returned to work. I began to travel around the world. I started a business using the skills that I have developed, and I began to confidently speak up about race, equity, and the community daily. And now I hang out with people who have a global reach and are changing the world. So I want to talk to you a little bit about taking care of family, being a caregiver, not necessarily family, whoever. I'm not sure what I see my computer, I see my screen bouncing, so I'm not sure what's going on there. But if in the comments, if there's someone out there, if you want to let me know if you are having a hard time seeing or hearing, and I will see what I can do about adjusting. Today, we're going to finish up talking about emergency room visits and what goes on with the emergency room. Um, okay, so I want to tell you to be prepared to wait for a little bit when you're in the ER. This is not like going to a regular doctor's visit. Um, it will not be a quick thing. Um, don't eat or drink anything on your way. Don't stop on your way to the ER to pick up anything to eat or drink because you don't know what's going to happen when you get there. So you don't want to have any food in your gut because you don't know if you'll have to have emergency surgery. So we're going to talk about what happens when test results come back. That's where we kind of stopped last time. You were being discharged after test results came back. If test results come back and it's determined that you need to be admitted to the hospital, this is what that process looks like. First of all, being admitted to the hospital can be a time-consuming thing. It involves a lot of things. Just because the doctor said you were going to be admitted doesn't mean they are going to move you straight to a room in the main hospital. Especially now in larger hospitals, you will find that I'm going to start this over again because I don't know what's going on with my computer. So let me end here. Oh, Dot said I sounded fine, so I'll leave it alone. Okay, thanks, Dot. Thanks for being on. Anyway, many larger hospitals now have a new kind of doctor, not necessarily new anymore, but you'll find this more in larger hospitals, I think, than you'll find in the smaller rural hospitals. And those doctors are called a hospitalist. So the Webster definition of a hospitalist is a physician, especially an internist, someone who specializes in internal medicine, who specializes in providing and managing the care and treatment of hospitalized patients. So the hospitalization that you normally see, the doctor who referred you to the hospital, or the doctor that you saw in the ER. So the days of your doctor coming and making rounds is pretty much over. We don't have a lot of that anymore. This is the doctor who will go through the records from what the ER doctor said, and they make the final determination about your admission. And sometimes they will disagree with what the hospital ER doctor said. So, then there's a big discussion about whether or not you'll be admitted or not, or if you can be treated at home. So when you are admitted, the other part of that process is that your records transfer from ER records to hospital records. And so a lot of things have to be changed. But the hospitalist then becomes your doctor of record. You might see some other specialists who are called in because of whatever the issue is going on with you, but your primary hospital doctor will be the hospitalist or somebody on that team, because there's a team of hospitalists. The same one is not there 7 days a week, 24/7, but there is a hospitalist on at the hospital, usually for at least for each floor or each type of care, all the time. So there is always a hospitalist at the hospital, at least one. So I need to clarify something. I have not been in a hospital since the COVID-19 situation has begun. Thank goodness we were out of there by February 27th. And so I can't tell you exactly what it looks like going to the ER or hospital at this point. Whatever you hear on the news or read is the same thing that I'm hearing and reading. So I just wanted to clarify that, because I don't want you to think that anything I tell you has anything to do with the coronavirus. It does not. I'm sure things are way different just from what I can see in pictures of triage. So I'm sure everything else is way different. Okay. So during our stay, and I say hour because with my parents and my children, I always stay at the hospital most of the time that they're there. I come home a little bit, but not a lot. So it's hour. It's definitely a joint kind of thing. And also, once we find out somebody's being admitted to the hospital, I tend to stay there until I have seen them move to the room they're going to. I don't like to leave them there in a state of flux. In particular, when I was dealing with my mom and my dad, my mother didn't have dementia, but the noise and the sounds in the ER could make her confused, because there was always so much going on and it was loud, and so that would confuse her. And I have found that does happen sometimes with elderly patients. And because my father had vascular dementia, it was confusing just to take him to the ER. To move him out of his normal situation, his normal routine. And he, I was fortunate because my dad was not, he was always kind and gentle. He could be stern, but he was kind and gentle. And so we didn't really have to worry so much about him being a problem or screaming or yelling or things that I have heard other patients do with dementia. So the biggest issue with him was he never remembered why he was in the hospital, and he never saw any reason to stay there. So he was always trying to get up and come home. So after he had a stroke, the room he was originally in was down the hall from the nurse's station. And I came back one day and they had moved him to the room right across from the nurse's station, because they had finally put a bed alarm on, and he still kept trying to get up and get out of bed and go home. And rather than call me in the middle of the night and let me know that, they just moved him because they had a vacant room. But the next day they told me, you're going to have to either stay with him or hire a caregiver. And since I couldn't stay 24/7, we ended up hiring caregivers to sit with him during the night, so that they could keep him, they could stay awake and they could keep him in the bed. During the last hospital ER visit, he was heavily sedated because he had broken his hip. But when he wasn't sedated completely, when he wasn't completely out, he was still trying to get up, and he could not remember that he had fallen and broken his hip. The pain would push him back, but until the pain would really kick in, he was still trying to get out. So during our most recent hospital and ER visit, it was the end of February this year. Once the admission had been made, we remained in the same room in the ER until after 10 a.m. was over 16 hours after he was brought in by ambulance. And that visit had a lot of issues, and I'll talk about some of them because they're pertinent today. But I'll talk about how to advocate for your patient, or the person you're taking care of, in complaining, at a later point, because sometimes there are things that you can handle right there, but sometimes you end up with issues that, while they affected you, they would really affect a lot of other people, and so they should be addressed beyond right where you're getting the care. One of the things that occurred that I had not dealt with at our last visit was the fact that there was a separate area for hospital admissions in the ER. I think in an earlier post, I told you that when we got to the ER by ambulance, my dad he was out in the hall in the gurney, and the ER is so full at the hospital that we were at that the gurneys were actually room numbers. It says a lot about our healthcare system and how much healthcare we need, even in larger cities, when there's not room for people in the ER. And this is after a second area has been opened, but there are still, the gurney itself is a room number. So over your head is A or B or whatever, however they are numbering the rooms. So at any rate, once Daddy was told he would be admitted to the hospital, a nurse came in and said to us, and the nurse who was in the room, "We're going to be moving him to such and such room down the hall." Originally, I said, "He has a room now?" Because they had just said it would be a little while. And they were like, "Oh, no, this is a room down the hall in the ER." So they were going to move his bed down 3 rooms, which made no sense to me. But what I did find out was, once people are admitted in the ER, a different nurse takes over who is part of the hospital. So while you're going into the system, you're still being taken care of, and all the things that need to be done are still being done, but they put you in a different section of the ER because there is a hospital nurse as opposed to an ER nurse. I packed up all of our stuff and I waited for them to move, and the move never happened. So after a couple of hours, I finally went back out. We were right across this hall from the nurse's station, and I looked for the nurse, and then I looked for the man who was, I guess, her supervisor, who had told her that we would be moved, and he was talking to somebody else. Another nurse asked me, could she help? And so I was explaining to her what happened. She said, "Oh, I don't think you're going to be moved." Well, after 2 hours, somebody should have come and explained that to us. But I understand they were busy, but still, communication needs to occur between the patient or the caregiver and the hospital staff if something changes. You shouldn't have to be always the one going to find information out. And what had happened was that because we were only 3 rooms away from that nurse's rooms, she could just walk. I mean, she had to come to the nurse's station anyway, and we were right across. So that was a decision that they made, and it was a good decision, but it was still something that should have been told to us. So now, because the patient comes under a hospital visit, or a hospital admission as opposed to an ER admission, you will receive another visit from registration for hospital admission. And you will get a visit from somebody from the pharmacy staff, because they need to find out your medications or the patient's medications and put all of that in the system. You probably still will not be getting your medications at the time that you take them at home. So don't expect that. You want to be sure that you get your medication, but it's probably not going to be on the same exact schedule that you took it at home. And don't stress about it. Just be sure that you get the medicine that you need. one of the reasons that it's good to, if you are able to, I mean, I know if you're like in a car accident or something, you can't take your medicine with you. But if you're going to the ER from home, carry your bag of medicines, everything that you take, your honor and your prescription medicines, along with the list that you have prepared of your medications. The reason I suggest this is because sometimes the medications that you take, especially if I had been going to the hospital, I'm on a specialty medication that has to be ordered because it's not something that most pharmacies keep in stock. And so sometimes if you have a rare disease, or if you're have cancer, or you have some other disease that you're taking a specialty medication for, the hospital is probably not going to have that in the pharmacy. So if you take your whole bag of medication with you when you leave your house, and they come back and say, we don't have this, we don't have that, if you are close by, sometimes you can run 15-20 minute drive that medication up and bring it back. They will relabel it in the pharmacy for the hospital to use. And of course, you'll need to be sure when you're discharged that you get your medication and take it home with you. And I have had to do that when Mama was in the hospital and she had specialty eye drops. I had to go home and get those eye drops because the hospital didn't carry them. One of the other things is the hospital might use a different brand of your medication. They are probably going to use a generic if there's one available, and their generic may not have come from the same pharmaceutical manufacturer that your generic comes from. So it might not look the same. They will make sure you get the correct dosage, but sometimes you take one 90 milligram pill and all they have are 30s. So you'll get 3 pills to make up that 190 milligram that you take. So when the nurse comes in to give you your medicine, you'll look and you go, I don't take this much medicine. And they'll explain it to you, but sometimes that can be a little disconcerting when you're in the hospital. You also, you might normally take medicine at 11 o'clock right before you go to bed. Well, they may bring it to you at 8:30 or 9 when they're doing bedtime medicines because you're in the hospital and they kind of want you to go into bed. I mean, you're in bed, but you just want to be sure that you're getting the correct dosage and the correct kind of medicine. The nurse will normally tell you, they'll come in and they'll say, okay, I'm bringing your whatever, and they'll explain to you, or they should explain to you what medication you're getting. So if they don't, ask them what they are giving to you or giving to your patient. Sometimes, we're dealing with human beings, sometimes an error can be made. You don't want error to be made on your behalf. It is important to find out what they're giving you. Okay, going back from medicine, the doctor or nurse is going to tell you if they have a room right away available for you, or if you're going to have to wait for some discharges sometime. And I used to think up until the last 2 or 3 times I was at the hospital with someone, they wouldn't discharge you after 6 or 7 o'clock at night. But that's not true. With managed care, you get charged by the day. If you're there after 12 o'clock at night, they will discharge you whenever they can. And so that can be frustrating sometimes because you assume you didn't get discharged by 7 or 8 o'clock that night. You're not going home. You didn't get discharged by dinner time. You're not going home. That is not necessarily the case. So that, you just have to, you don't know what time you'll get moved to a room if the hospital is full. It just depends on when they discharge the patients. I do want to say you're still going to be treated if you're awaiting a bed in the main hospital, just as though you have been admitted to the hospital. Whatever tests you need to have, whatever medications you need to have, whatever doctor visits you need to have, you will still have those. So do not despair that you will not. Once you're being admitted, or even when you're in the ER, once they have done your test, if you were hungry when you got there, if you're hungry now, ask the nurse if you can have something to eat. If you have been admitted to the hospital and you're hungry, and you just tell the nurse that you're hungry, and they can check and see if or diet have been put in the computer for you. Once that occurs, especially if you have been put on a specialty diet, they'll give you the menu and they'll tell you how to get in contact with the cafeteria. And you can, when you call to place your order, or when you call to place the patient's order, they'll say, they'll tell you what room number, or however that hospital does it, but they will tell you what to do. And the folks in the cafeteria, when they answer the phone, can at that point say, you are on such and such a diet, you can order such and such, and you can go ahead and place an order, and they'll deliver your food to you where you are. If you are in pain, we're going to go back and talk a little bit about medicine here. If you are in pain, ask the nurse what your medication schedule is like. They will tell you when, and ask them, okay, you give me pain medicine now. When can I have pain medicine again? And is it scheduled? Will you just automatically bring it to me? Or is it PRN as needed for pain? And if it's PRN as needed, do I need to request it? Or are you going to come and ask me if I'm having any pain at whenever my next dosage is due? There's a huge difference. I thought I understood that, but I didn't at our last visit. So I was told that Daddy could get pain medication as needed. And she said he's due for it. I thought she said at 2 a.m. I think it must have been 2:40. Anyway, she didn't tell me that he had to make a request for the medication. So I assumed she was going to bring it around 2 o'clock. And I pressed the call button about 2:10 to ask for medication, or, and I said to the person who answered, I said, it was time for his medicine, and I'm just calling to request it. She said she would tell the nurse. At 2:30, 30 minutes later, or 20 minutes later, I still hadn't seen the nurse. So I stuck my head out the door, because the nurse's station was right across the hall. I saw the nurse sitting at the chair, and one of the aides who had helped him looked at me, and she said, "Does he need pain medication?" I said, "Yes." She tapped the nurse on the shoulder and said, "Pain meds," and pointed at me. The nurse turned around and looked. I thought she was looking at me because I had been talking to the aide. So I went back in the room. Another 20 minutes passed, and we still didn't have any medicine. And so when she came in, I said, "I thought he was due his medicine at 2, and it's almost 3. And she said, "No, he's not. He's not scheduled for some more until 2:40, and it's about that now." I said, okay. I said, "But why didn't somebody tell me that when I came out?" I said, "I called and you didn't come." And I came out to the nurse's station, and when the aide tapped you on the shoulder, and so before I could say anything else, she said, "Nobody tapped me on the shoulder." And I said, "Yes, she did. I saw you." I said, "And she told you that I needed pain medicine, or that Daddy needed pain medicine. And you turned around and looked, and I went back in the room." And she said, "That didn't happen." I said, "Well, whatever, just give him his pain medicine." At which point she told me that he had to request the pain medicine. Well, I mean, he was kind of out of it, but he also has dementia. He didn't remember he'd broken his hip until he would try to get out of bed. So, that was just crazy. So anyhow, she went out and got his medicine and brought it back. And as she was typing the information into the computer, that's one of the ways that they verify what they're doing. When they come back in the room, you'll see them go to the computer and type stuff in and look, they look again, and then, they take the little scanner and they come and they scan your bracelet. All of these are things to verify that what they're doing is giving care to the right person. Don't ever let that disturb you, because that's an important step. So anyway, she came back in and she's typing in the computer, and she said, I thought about it. I did get asked about pain medicine. She said, but I had pain medicine there for the person in the room beside your dad. And so I I wasn't looking at you. I was looking at the room next, and I went in there and I gave the pain medicine. Um, and so, we cleared it out. I didn't scream. I didn't shout. Sometimes I've had to be loud. That's not normally my way of behaving, but I do find that screaming and shouting does not help get anything done any faster. But that's a whole nother topic. So she thought she had done what had been requested. And so we worked that out. But what was frustrating to me was that if an elderly patient or someone with dementia or somebody who cannot verbally request the medication comes in, and they're the people who have to request it, and they mentally cannot function to do that, how do they get their medicine? That bothered me. So that was something that did have to be addressed, and I addressed it much higher up than the nurse because it needed to be addressed at a higher level. And it wasn't just a my daddy thing. That was something that needed to be addressed for people in general. And so a lot of times, if I have an issue about anything, and it's something that I think will help the general population and not just me, I will address it at a level that can handle it for a larger group. Okay, that's another discussion as well. So at some point, when a room in the main hospital is ready for the patient, the phone call from that nurse's station to the ER nurse's station, and the patient will then be transported to the main hospital. You'll be told before you're transported or before they're transported what room number you're going to, and then you'll be moved. When they tell you that they're going to move you, they will normally give you a bag, and you go ahead and start gathering all of the patient's belongings. And generally they'll tell you, they'll just put that on the side of the bed so that when they transport the patient, they can transport all their belongings at the same time. If you're the caregiver and you're with the patient when they're being about to be transported, look around the room, especially in this day and age. Check the outlets and make sure that you did not leave your phone charger plugged in the outlet, because somebody else will take it, or it'll get gone, or there'll be somebody in that room when you think about it and you don't want to go and disturb them to try to get your stuff if it's still there. Once you get into the room in the main hospital, the ER nurse will hand over to the nurse for the patient that's on that floor. Generally, the nurse will then recheck all of the patient's vital signs after they get the report from the other nurse, make sure that the patient is comfortable and they have everything they need. If you are comfortable at that point leaving and going home to get some rest, if you can do that, go ahead and do that. However, if you're not comfortable leaving, or if you don't live close by, most hospitals now have a reclining chair in a hospital room so that somebody can stay there with the patient if they would like to. And they can probably give you a pillow and a blanket as well. Nurses and the other hospital staff will be in and out to check vitals and collect blood samples as they need to, all during the night when you're there. So you don't really get a lot of rest, but at least you are a little more comfortable than sitting in a straight back chair. Thursday, we'll talk a little bit more about the hospital stay and what that's like. Things that you can do to facilitate that, and what kind of things you can ask people to do for you to help you while you are caregiving a patient in the hospital. If there are things that you need, we may come up with some more list of things that you might want to take, because when you go to the ER, you don't necessarily know that you're going to be admitted to the hospital, or the patient is going to be admitted to the hospital. So you may not be quite as prepared for that as you think you are. Thank you so much. If there are things that you would like for me to be specific and talk about, please put those in the comments. We will be going live again this Thursday at noon. And I look forward to seeing you then and help you learn how to take care of us. Bye bye.